My name is Dr. Samir Kakodkar. I am a gastroenterologist and also a specialist in ulcerative colitis and Crohn's disease. Welcome to Against the Grain. I have no conflicts of interest to report, and all podcasts are free. They can be found at samir3.podomatic.com, or if you search my first and last name into the iTunes app, you should find it as well. I have a YouTube account, I have a Twitter account. Those can also be found by searching my first and last name. I do post on Twitter prior to these interviews so that I can get questions from you guys and I can ask the guests whatever you're curious about. So please become a follower, and then you can get some of your questions in as well. Barbara Olendzki is Associate Professor of Medicine and the Nutrition Program Director of the Center for Applied Nutrition at the University of Massachusetts. She is passionate about research and clinical care of patients with inflammatory bowel disease, cardiac concerns, cancer, diabetes, obesity, and other inflammatory diseases. She has 20 years of experience in the nutrition field. She created the IBD Anti-inflammatory Diet, also known as the IBD-AID, which is based on the Specific Carbohydrate Diet, but with an emphasis on pre- and probiotics, healthy fats, and textures of foods. It also includes certain carbohydrates like oatmeal and other foods that are otherwise forbidden on the SCD. She published a case series in 2014 of 11 patients with IBD who went on her dietary protocol. Most of these patients had failed one or more medications, or medications had no effect, or there was a loss of response. After using the IBD-AID diet, all patients were able to de-escalate medical therapy to some degree, and all had symptoms reduced. Since that publication, she has updated the protocol and kindly shared her insights regarding implementing the IBD-AID clinically. As a disclaimer, this is not an endorsement or recommendation of this diet for the treatment of Crohn's or colitis, as the IBD-AID has not been FDA approved for this purpose. All right, so Barbara, again, thank you so much for making time on a weekend to talk to me. You're someone that I've really wanted to speak to for a long time. And actually, through this podcast, many people have reached out to me to interview you. So you've been one of the most requested guests I've had so far. So thank you so much for making the time.
It's a pleasure.
So can you please tell us about your background and your training?
I am a dietitian or nutritionist, which may be a friendlier term to some folks. And although my first degree was in fine arts, and so I sort of came by this with a personal story, and maybe that's true of many folks at why they do what they do. When my second son was born, he was born with a number of allergies, and I found myself addressing it with changing my own diet and learning about what I needed to do in order to feed himself and also me, where I had several autoimmune disorders to address. And in this pathway, decided that I needed to go back, got a master's degree in epidemiology, and continued my path with nutrition and focusing on components that could be applied to autoimmune diseases and diseases of inflammation. Started over 20 years ago at UMass Medical School, working in cardiology with cardiovascular patients, and then started expanding my practice to diabetes and ultimately to gastroenterology patients. So that's kind of it in a nutshell. I do a fair amount of research. I also do teaching in the medical school and other places, and my clinical outpatient work.
Mm-hmm. Great. And how specifically did you get involved? And I did actually search you on PubMed and saw like lots of publications in various different fields of medicine with regard to nutritional aspects, but specifically for inflammatory bowel disease, Crohn's and colitis. How did that get on your radar?
It got on my radar with a gastroenterologist who sent me a patient and said, we've tried everything with this patient and they want to do the SCD, the Specific Carbohydrate Diet, and so we're sending them to you. And so the patient arrived and we did this Specific Carbohydrate Diet, of which at that time I was, really not knowledgeable, but I thought, well, this is a crazy diet. And it worked. And so the researcher in me kicked in, and I started looking in specifically into components of the SCD. And with what I know about, or knew at that time about inflammation, I started researching those various components that Elaine Gottschall had proposed. And in my terms, there may be some who object to this, but I've updated the specific carbohydrate diet so that it's not just about carbohydrates anymore. It's about various other components that we now know need to exist in order for a patient with an autoimmune disease such as IBD needs to address. So kind of a long-winded way. And so at that point, and many years later, I am still updating the diet. And so it's not a static diet. It's a diet that is hopefully goes head-to-head with the current research in the microbiome and inflammatory bowel disease, and specifically applying that research on sort of a continuum. And that's why it's a bit hard to publish, because once you publish, it sort of doesn't change anymore. And I find that we really need to keep learning about nutrition, diet, and IBD.
Mm-hmm. And what are the limitations you saw in the SCD when you first learned about it that led you to want to update the protocol? Because it's interesting you say it's not a static diet. Yeah, I received an email recently from somebody who used a very good term. She said that the SCD is almost like frozen in time. It's something that a lot of people found helpful, decades ago, and has not been significantly updated since Breaking the Vicious Cycle was published. Maybe you can make an argument that on these forums that people are kind of troubleshooting it and updating it, but there isn't like an official voice as far as bringing it forward. And that's part of the reason I'm doing this podcast. A lot of them are related to diet, and I also am reluctant to publish things about diet because my attitude is always evolving over time as what I believe is optimal, and as more research comes out. So I think the people who listen to this, with each episode, we're getting closer and closer to hopefully the truth, what's really going to help most people as far as dietary advice. So you knew about the SCD, and what was it about it? Because it seems like that first patient responded very well to it that you encountered. Then what was the impetus for actually updating it and trying to improve it?
Very, very good questions. So what I wanted to do at that time, and still do, is identify the components of the diet that work well and the components of the diet that are most essential to success. And then there's a whole host of other foods that should be customized to the patient genetics, lifestyle, and needs. So the specific carbohydrate diet really is about carbohydrates and doesn't recognize distinctions of different fatty acids, of which we know from both diabetes and cardiovascular disease need to have some distinctions, the good fats and the bad fats, if you will. It's also that the SCD, and Elaine was brilliant for her time, and she really did set as a pioneer the stage for where we're going now. But she didn't recognize prebiotics, and prebiotics are the food supply of beneficial bacteria. And we know from our studies with the microbiome, where we're actually measuring the good guys and the bad guys, that if we introduce prebiotics, that the good guys will come. It's still a mystery to me where they come from, because they could be previously undetectable, but they do come. And so we can increase diversity and quantity of beneficial bacteria through a consistent intake of prebiotics. And we are still discovering these prebiotics. It isn't something like a vitamin or mineral where it's been on the USDA's radar for a long time. These are components of foods that the bacteria prefer. So ask me another question and maybe we can get some more clarity there.
Mm-hmm. Yeah, I know from my recollection of Breaking the Vicious Cycle, she did talk about some, and what comes to mind is fructooligosaccharide. And
Yeah.
I know she said it actually was something in her experience. She felt like patients got worse when they were taking that. And maybe that colored her philosophy on it. But and I do want to talk to you a little bit later about like the phases and using prebiotics in the setting of inflammation and not inflammation and being in remission. But yeah, I know she specifically mentioned FOS, but and that is one of the key distinctions between the IBD-AID diet and SCD is one of the things that's emphasized.
Yes, but it's food sources of FOS, the fructooligosaccharides. And so the FOS is a FODMAPs, which is another concept we might get into. And it can be, and so this is upstream of disease, difficult to digestion. And so we need to work with a patient's digestion in order to improve absorption and symptomology, maybe related to bloating and that kind of thing. Downstream is where the systemic effect of foods takes place. So there's sort of a distinction between acute reaction to food happening maybe within 2 to 5 hours of consumption and systemic effect of food, which is what we see with not only IBD, but also cardiovascular disease, diabetes, et cetera, to some greater or lesser extent. In other words, you don't feel it in your heart when you've had a fatty meal or a meal high in fried foods, but it's definitely going to affect your heart.
Sure, and that goes with this whole concept that I've talked about on previous podcasts about symptoms versus inflammation. Like certain foods can make you feel symptomatic. Like if you eat a bunch of prunes, it can make you have diarrhea, but that's not necessarily affecting the inflammation or the disease progression of Crohn's or colitis. Okay, so can we just now go into the nuts and bolts of the IBD-AID diet, which stands for IBD Anti-inflammatory Diet?
Right.
And I know we talked a little bit before about how your philosophy has actually evolved since that initial 2014 publication and that case series you published. But as far as just the basics of it, I wanted to go through those like 5 components you've mentioned. So first, modification of certain carbohydrates. What's involved with that?
So what we do, and there is a foods list recently updated on our website, which I can send you the link to. What we do is essentially eliminate, and that's one of the components, is avoidance or limiting of adverse foods thought to be adverse for various reasons, one of which is they are thought to feed the adverse bacteria, and that would be sugar, lactose, which is milk sugar, wheat, corn, which is gluten-free, but also adverse. And I have some thoughts or a hypothesis on the why of these. It's maybe and probably not only related to gluten in these foods. And so avoiding these particular carbohydrates, also high-starch foods like white potatoes, although in the IBD-AID we have integrated sweet potatoes with some great success.
Okay. What would be the distinction between white potatoes and sweet potatoes? Just the more starch content in white potatoes, and it's just why would one be better than the other?
Okay, so this is where we get into some individual response. But if we have somebody who has metabolic syndrome, which you probably know, but maybe your listeners may not, it has to do with how you process sugars and insulin. And so the white potatoes are going to incur a quicker response than the sweet potatoes with regards to the digestion, absorption, and sort of the metabolic processing of those sugars and the insulin response. It can be inflammatory if it's too quick for the body, or the body processes too quick or generates too much insulin. Then we see storage of the sugars if the individual is not using it for energy. But it's not only the glycemic response or glycemic index of the food, it's also other components of the food that will, again, act as prebiotics for the beneficial bacteria while not feeding adverse bacteria.
Okay. And you also limit lactose, right? Lactose is another carbohydrate that's excluded?
Yes.
Okay. And then the second component is, again, you mentioned this, but strong emphasis on the ingestion of pre and probiotics to help restore the balance of the intestinal flora. So I believe we've covered that. Go ahead.
We talked about too much. So we've talked about prebiotics, and prebiotics are foods like that are on the FODMAPs list, like onions and leeks, asparagus, all the fruits and vegetables. Prebiotics also are the oats, and I recommend like oat groats at this point for a larger particle size, as well as the effect that they have had on the microbiome. Probiotics are foods that contain bacteria. And so what we want to do is get a variety of probiotics because one of the things that we've learned is that the beneficial bacteria don't act in isolation. In other words, you can't just take acidophilus and expect that you will have something that will solve your problem. It's a colony of beneficial bacteria that act together with particular functions. So we want to get a variety, and that's why I have miso, good quality miso on the diet. We also I do have some folks doing kombucha, although there's a lot of sugar in a lot of the kombuchas out there, so buyer beware. Kombucha is also a source of a probiotic yeast called Saccharomyces boulardii, which can be quite helpful at repairing gastrointestinal permeability, which is a common problem with IBD. And that GI permeability has led itself to an idea, well, it doesn't matter what I eat, everything hurts.
Mm-hmm. And what is your thought about probiotics as far as, because it seems like you have to eat them on a regular basis, right? These strains that usually are found in probiotic foods or supplements, it's my understanding, correct me if I'm wrong, is that they don't tend to most of the time colonize, and they eventually all get shed out in the stool. So you have to take them on a regular basis. Is that true?
I think we don't know everything about what happens. We do know that if you ingest them, you certainly need to feed them if you want them to stick around.
Mm-hmm. Okay.
And so we do see changes in colonies in the stool based on probiotic intake, but we see, especially with some patients, more of a change with intake of prebiotics.
Mm-hmm. Okay.
But the two go together. They're complementary.
Okay, and what about the fats? You mentioned there are good fats and bad fats. For somebody with Crohn's and colitis, which are the ones that they should avoid?
So bad fats, definitely hydrogenated oils or partially hydrogenated oils, unsafe for human consumption. And so you need to look at the ingredients list of the food that you're about to buy and see if it has any of those in it. And they still remain in the food supply, even though the FDA has declared them unsafe. So trans fatty acids, that's the same thing as the hydrogenated oils, but the commercial producers are allowed to list trans fatty acids as 0 on the label if it contains less than 0.5 milligrams per serving. So if you buy a popcorn, for instance, the microwave popcorn, it can list as 0 on the nutrition facts, and then say you eat the whole bag, which most people do. It's in the ingredients list, and you're actually consuming. Now we know that there isn't a level at which hydrogenated oils are safe. So that's definitely a bad fat. Saturated fat is one of those fats that you can consume within certain limitations and be okay. And so it's usually, if you want to calculate your sort of caloric needs, a lot of online programs will do that. You want it to be less than 7% of your intake. The reason for this is that if saturated fats are in excess to beneficial fatty acids like monounsaturated fats or omega-3 fatty acids, they are in competition within the immune system and go down a different, or carry the body down a different pathway that is much more inflammatory. Mm-hmm. And so this is where we see diseases of inflammation and chronic disease, including IBD, have difficulty. And there are certain foods that are very high in saturated fat. Dairy comes to mind, but also animal fats.
Mm-hmm. What do you think about? There's a lot of people in the low carb sphere who can get upset whenever anybody says, you should decrease saturated fat. And according to a lot of the cardiologists I speak to, they demonize saturated fat and say, people you should limit it as much as possible. But I think your message of moderation to, not eating it in excess, but your body does need some saturated fat. Is that correct? Is it a good idea to try to completely eliminate it?
I don't think it's a good idea to completely eliminate it. It's like having a bank account. You can spend a certain number of grams on an average, and so that average for somebody consuming 17 to 2,000 calories would be like 15 to 17 grams per day. I may be a little off in my calculations, but that's kind of, so you can spend it. You don't want to spend it all at once or all in one place, but to spread it out. And you want to include the beneficial fatty acids, if not at the same time, at least within the same day.
Okay.
And most foods are a combination of all these fats.
Right.
So like olive oil is predominantly monounsaturated, but it has 11% component saturated fat, but it's still okay.
Mm-hmm. And do you make any distinction between meat-derived saturated fat or animal-derived versus, for example, from like coconut oil, or do you consider it to be equivalent?
It's not equivalent, but I'm still leery, or I have become more leery with some recent research on coconut oil. I think it's metabolized different. It's a shorter chain saturated fat than the animal fats. It may be beneficial topically, for instance, and but I don't know. I'm waiting for the research to come out specifically on coconut oil and inflammatory disease.
Okay. So what do you recommend people cook with? Because are you okay with like vegetable oils or corn oil or peanut oil? Because the SCD diet doesn't really make much of a distinction as far as you should be cooking with this. And you're right, it's not very specific about what fats you should be limiting or including in your diet.
Yeah, that's a really good question, and it is a complicated answer. I do simplifying. Olive oil is great at low to medium temperatures, like for salads and that kind of thing. Avocado, it really opens it up because they're cold temperature, and you want to get the cold pressed oils. Avocado oil, flaxseed oil. It's got a strange flavor, but it's got some omega-3s to it. You can add a little bit of orange juice, and you've got a dressing. For cooking, it depends on the temperature again. So canola oil, if it's processed correctly, can be an option. It does contain some omega-3s, and it is predominantly monounsaturated fat. We need to be careful when it gets to be like corn oil. I do not recommend the omega-6 oils like corn oil or sort of the general vegetable oils. I like cold-pressed organic oils.
Okay.
Peanut oil, maybe from time to time if it's, a higher temperature cooking and you're looking for that particular flavor. In other words, I guess I don't prescribe to a legal, illegal view of foods, but have recognized that if my patients comply 80 to 90%, depending on their current symptomology, that they can get where they're going and still have the occasional this or that is not on the diet.
Okay. And, some of the people in the paleo community like using ghee, and some people like butter. It seems like from your perspective, you'd want to limit that, correct?
Limit, but not necessarily avoid altogether.
Okay. All right. So then the fourth component is a review of the overall dietary pattern, detection of missing nutrients, and identification of intolerances.
Yeah, this is really an important part. And so I do an assessment with my patients, and I'm not sure that patients themselves know how to do it on themselves. And that's where we look at predominantly not only macronutrients, carbohydrates, protein, fats, that's like the broad strokes, but it's what makes up the micronutrients. What are the different parts that define those macronutrients? And this is where we can get into people who fall into habits of even people who are on the SED or the IBD-AID having too much almond flour, for instance, because they're looking for bread alternatives. And in doing so are missing out on, say, some fruits and vegetables with those nutrients that are essential for human life. And especially with kids who are growing, women who are pregnant. We're doing a study now in pregnant women with Crohn's disease and changing the microbiome in the third trimester in order to help the babies be born with greater diversity of microbiome that can help to protect them from autoimmune diseases. So there's just some fascinating areas that we're now learning about where it's essential to look at not only the pre and probiotics and avoidance of certain foods, but it's inclusion that is key. So it's 3 parts add and 1 part subtract, avoiding foods that we think to be adverse and adding foods that are essential. And it's fascinating to me in the studies that I've done that it appears to be easier for people to cut foods out of the diet than it is to add new foods or new ways of doing things. This is where behavioral change takes place, and where we're working with the psychology of the patient to be able to help them change their lifestyles, integrate new food flavors, new ways of preparation. It could be, I've never blenderized foods, or I've only microwaved foods, or how do I shop for these things? What do I look for? What do I eat when I go out to restaurants? It's not easy, but once you jump into it, and with the right frame of mind, so to speak, of going on an adventure or taking a journey, it becomes just what we do after a while. And it's not difficult anymore to avoid these foods, to avoid bread, for instance, which is ubiquitous in our society. It's just what we do, because there's other foods, and part of the strategy here is to plan ahead and make sure to always have good foods with us. Mm-hmm. So everywhere I go, I've got a lunch box, and I have a certain set of foods that I know I can order when I'm going to restaurants. It may or may not sit well. Digestive enzymes are another tool in the toolbox that are very helpful for patients that have difficulty with breaking foods down. It could be that what we're dealing with, for instance, when I hear patients who are successful with FODMAPs or removing the prebiotics, that basically it's an enzymatic deficiency. Adding in a good digestive enzyme, taken 1 or 2 caps prior to consuming these beneficial foods, can take away the bloating or dyspepsia that can occur within a few minutes to hours after consumption of these foods, and bring back nutrients in the diet that are essential for well-being.
And from your perspective, what would be a good digestive enzyme for that particular indication? Because I feel like in my field, we're really only using digestive enzymes for people who have pancreatic insufficiency, and people also have a lot of insurance issues getting the ones that are approved now. Like Crohn is a popular one, but it tends to be very expensive for a lot of the patients I prescribe it for. Is there another brand you recommend that can be gotten online?
Digestive enzymes actually aren't that expensive. And there's a number of them. And what we're looking for is anything ending in ASE, like lipase is what Crohn is. It's for digestion of fats, which is problematic for folks with pancreatitis. We also see it with our IBD folks where they have something called steatorrhea, where they see fat or oily on the surface of the toilet water. That is a malabsorption of fats. There's also malabsorption of other nutrients, like we might look at legumes or beans, especially in the Caucasian population. They may have trouble with this. And that's where, after I eat beans, I get a lot of gas and bloating, and it can be quite painful. Having an enzyme, alpha-galactosidase, that is usually within these multiple digestive enzymes can be really helpful, so that we've got all of a sudden somebody who can now tolerate those beans, and they could be pureed for increased digestion and absorption. So they are available off Amazon. You need to be careful and look at the ingredients list. This is where we get into yet another topic of emulsifiers. Maltodextrin is a common adverse emulsifier that can be added to anything that's processed. And it could be in nut milks, it could be in frozen foods, it could be in and is in a lot of these supplements, meant to sort of hold them together. But a lot of supplements now supplement companies are recognizing that they don't need it and are leaving it out.
Okay.
And I don't know if within your podcast you recommend particular brands, but we can go into some ideas I have off the top of my head if you like. And xylanase, XYLANASE, is very helpful for digestion of fructose. And sometimes we will uncover, every time I eat these fruits, I get diarrhea and it's uncomfortable. It can be a xylanase deficiency. Mm-hmm. And so you want to then customize your digestive enzymes to have a higher level of that xylanase.
Okay. And the last component of the diet is this modifying the textures of food as needed per the patient's symptoms. So can you talk a little bit about the importance of texture?
Okay. And so it used to be years ago that we said, you need to avoid any foods that have any fiber in them or any texture. Go for the white bread, go for the cheese, go for the hamburger. So these are high saturated fat, low nutrient density foods that actually caused an increase in systemic disease. What we want to do is actually modify the texture of beneficial foods. For instance, oats you can put into the blender after cooking. You can put fruits and vegetables into the blender, make them into soups and stews and dips and puddings and purees. And I equivocated in folks who are would like to look at it this way, and to we kind of reset the gut as we would not feeding babies foods that can be difficult to digest. So we go easy on the gut, but we increase the intake of nutrients that are beneficial for solving the problem, not just keeping the gut quiet, but actually putting the patient into remission and decreasing the inflammation of the body.
So would you say the texture, the importance of the texture and modifying the texture of the foods is more just so the patient can tolerate what they need to get to help with the disease course of Crohn's and colitis, and not necessarily it's the textures that are improving the inflammation, right? That's my understanding of kind of what you're trying to accomplish there.
Well, for instance, if the patient eats a food that's high in fiber and doesn't have a good digestive ability, which is very common, what we get is a food that can bounce around in the intestines and nick friable tissues and actually cause more bleeding.
Okay.
But if we puree that fiber so that it's like baby food, then it doesn't cause harm to the friable tissues, and the patient, because it's sort of mechanically pre-digested, gets a better absorption of the nutrients of that food and can heal quicker.
Okay. The way I was trained regarding people with strictures, with Crohn's disease, regarding their diet, was for them to chew their food well, chew it to pureed or liquid consistency before swallowing, and to avoid foods that are hard to do that with, like asparagus, celery, popcorn, that type of thing. Is that sufficient from your perspective, or do you think people really need to blend their food, especially if they're in that early phase or are very symptomatic with a lot of inflammation?
I've never known anybody to chew their food to pureed consistency with long term. It just, busy lives. And part of what we want to do is providers is to be able to give people back their potential of living a normal life. And so in folks who have the strictures, where we really cannot have certain intact foods, almonds is a biggie, actually. I've had way too many people react to almonds, where almond butter is fine. So that is the same food that is an example of being pureed. Mm-hmm. So the certain foods I would advise. I'm so cautious when it comes to strictures. I would say, okay, you just can't eat celery anymore. Mm-hmm. Not whole like that. You may not be able to have asparagus anymore, unless it's like the really soft tips. But it tastes great in like a spinach and artichoke and asparagus dip made with a good quality yogurt and lots of herbs and spices, and it's fabulous that way. So we get the nutrients, we get the components without causing harm to the patient.
Mm-hmm. So can you just briefly go over the phases of the diet? There's the 4 phases and how somebody determines going from one phase to another.
It's actually 3 phases. The GI docs told me that 4 phases was way too complicated, and I agree. It's now 3 phases. Okay. The first phase is for when a patient is in a flare, or having a lot of troubles with their digestion. Bleeding is a good example of that. So it could be that the patient who's deciding to initiate the diet doesn't have to start with phase 1. Phase 2 is a patient who is not currently bleeding. They are coming out of their flare or not in a flare, but still have some ongoing symptoms. Could be bloating, it could be diarrhea. Also, I have about 10-15% of my patients who have constipation, and that's treated in different ways. We modify the diet a little bit differently for that. So that's some of the foods allowed in phase 2. We also have some softening of the foods, but include a lot more textures. Phase 3 is foods that require higher enzymatic ability than the other foods, as well as getting back into now the tissues are no longer friable, and so that's a maintenance phase. I'm learning a lot more, Samir, with regards to genetic enzymatic capabilities, where someone who is from Asia naturally has those enzymes better able to tolerate legumes and cruciferous vegetables. And so in that case, and so a lot of the phase 3 foods have legumes and cruciferous vegetables, but I may start somebody with those genetics earlier than a phase 3, but we might modify the textures so that they can digest it easier. So it may be more of a texture rather than enzymatic problem. Does that make sense?
Mm-hmm. Yeah. And what about oats? Because I think that is a sticking point for a lot of people who are strict SCD, and then they learn about your modifications. That's a major deviation. At what phase is that okay to use or okay to introduce?
Well, maybe a lot of your listeners are going to sink back in horror, but I'm also integrating barley now. So we may start in somebody, let's say I've got somebody who's really in a flare. They're actively, bleeding. And I might start them with oat or barley water, interestingly. Mm-hmm. And that can, what we're doing is changing the microbiome, as well as providing nutrients at that time. And I can maybe send a link to a patient who did stool studies from SCD to the only thing that we added, because the patient was frightened actually of adding anything from the IBD-AID, the only thing we added was ground flaxseed, which doesn't have any carbohydrate in it. We did that. He found a change. Still wasn't where he needed to be. Start adding oats, and then we had another change in the microbiome, significantly improving his digestive ability. But also, there's another component, the microbiome, the good guys. Why do we want them? Because they produce short-chain fatty acids that key into biomarkers called cytokines. And these cytokines are also what the biologics are keying into, but we can do it through food supplying beneficial bacteria which produce these short-chain fatty acids that key into the cytokines and shut down the inflammation. Mm-hmm. And so ultimately what we want to do is integrate these prebiotic foods so that the microbiome can manage the disease.
Mm-hmm. Yeah, it's interesting that you bring that part up, because I just did a podcast, actually 2 podcasts ago. I did one with a physicist named Michael Briggs, who came up with his own protocol that's pretty popular in a lot of forums for ulcerative colitis. And he also brought up this issue of eating carbohydrates or fiber in order to produce the butyrate, for the bacteria in the colon to produce the butyrate, which has immunomodulatory properties. But that butyrate, that transporter in the colonocytes, to utilize the butyrate is downregulated when there's active inflammation. So that was his explanation for why certain people with active IBD can't tolerate fiber, because it actually makes them feel worse because they can't uterate that butyrate, and it can actually be pro-inflammatory in that context. But once inflammation is under control, then that's when the carbohydrates and the fiber can have that beneficial effect.
So inflammation is so complicated, as is the immune system, and it has so many variants to it. But I do see that when we take that fiber and we put it into a puree, it doesn't cause inflammation. It's the opposite.
Okay. So have you had a lot of patients? I'm sure you see a lot of patients who are on strict SCD, probably not getting where they want to be, and you feel like introducing oats, or which you mentioned, oat water or barley water, and that can sometimes turn people around?
Yes.
Wow.
And then as they improve and their digestion and absorption improves, then we increase the textures and we get further improvement. And it can go really fast. Kids respond very quickly. It could be within a couple of weeks, even days, of people responding. I had one fellow, and he went on the diet. All of his symptoms resolved. Went on a golf weekend. His symptoms all came back. He went back on the diet, and 3 days later, he's fine. And so, and some of this I recognize isn't necessarily only the diet. It's genetics plus diet, plus probably environmental factors. So I think it's a mistake to look at diet alone when it comes to IBD. We really need to incorporate what else is going on and best address all of these factors when recommending a course of lifestyle change.
Okay. And what exactly is oat water? How does that prepared?
And so what we do is I would take, say, the oat groats, which are available off Amazon, not as readily available in the stores yet, and cook them up in an Instapot or a crock pot where they're really well cooked with double or triple the amount of water, where what you've got is the oats, but they haven't been able to absorb all of the water. And then in addition, we might throw some kombu, which is a seaweed that you can put into the cooking water of foods that you're having trouble with, and it can actually help with digestion. So it can help with gas from beans. It can help with the digestion of oats, and you don't have to eat the kombu, but it imparts its wisdoms, if you will, to the water. And so that water then can be consumed as a broth. You can even add your bone broth or something like that to it. And then as the patient improves and their symptoms reside, we can start adding the oats themselves in to the diet. Still soft, maybe pureed, and just so we go according to the patient timetable. When they're ready, we advance.
Okay, and I had some specific questions about foods that I would be curious about your commentary for these specific foods that are allowed on your diet. So almond milk and soy milk, at least according to the 2014 publication, these were things that were allowed early on in the phase 1. Any comments on like what kind, or because a lot of them have additives in them and carrageenan and other things that may be problematic.
Buyer beware. Seems like a healthy food, but you've got to read the ingredients list. Carrageenan is to be avoided, and as are a lot of other emulsifiers. Guar gum may actually be beneficial. And all of this may come down to the manufacturer themselves. And on that level, they can just sort of list guar gum in the ingredients or other foods in the ingredients. But depending on how they're processing it, they may not have to reveal that. It may be next to impossible for the patient to actually digest. Okay. It's too compressed, or maybe there's other components that are added from that list that the USDA says is generally recognized as safe but doesn't have to be included on the label. It's a tricky food supply that we have to navigate.
At guar gum, my understanding is that a lot of the coconut milk preparations in cans have that in it. Not all. I think there's a couple brands that at least don't list it. In the paleo community, I think guar gum is allowed. I see it in a lot of paleo, at least products that are available in the store. So from your perspective, you're not too worried about that?
Because there's some, I did some PubMed searches on guar gum, and there are actually some beneficial research as it pertains to ulcerative colitis and guar gum. I think, again, we need to do more research. I don't necessarily say we need to put guar gum in. If you can avoid it, I'd say absolutely get as simple ingredients as possible. So I guess I'm not saying I'm not worried about it. I'm just saying I'm not as worried about guar gum as I am about carrageenan and polysorbate 80 and carboxymethylcellulose and some of these other emulsifiers.
Okay. What about yogurt? Yogurt is something that's very integral to the SCD diet for most people. Most people do eat it on a regular basis. How do you integrate yogurt in your diet?
Yogurt, I think, is wonderful. I think the more variety of organisms, and now we are processing yogurt where it preserves the organism, whereas in Elaine's time, we did not. We destroyed the organisms. I think homemade yogurt is fabulous, but I also have patients doing well with varying the probiotic cultures that they're putting into their yogurt. And I think this is a good idea. We need to get a variety of beneficial organisms, not just 3 of them. I think 8 is better, 10 is even better. If you can get 30 of them in there, why not? Because we don't know which organisms are missing. We haven't come to a point where clinically the patient walks in, drops a stool sample, and I can say, oh, okay, you need this bifidobacterium or that. We have to throw the variety at them, hoping that one or more of them is going to catch. So we've got a long way to go in clinical care, especially, but in research too, to reach a level where we know what people need.
So you still recommend lactose-free yogurt, though, right?
I do.
Okay, but not. And you said the yogurt of Elaine Gottschall's time was actually killing the organisms in the yogurt. Is that? Do you mean
the commercial yogurts?
Oh, the commercial yogurts then.
Yeah.
Okay.
So I have many people who can consume commercial yogurts and do very well. They don't necessarily have to make their own. So that was my point. So that has changed. Yeah.
And is there, I think when I spoke to you years ago, you had talked about, there's a brand called Green Valley yogurt, which is lactose free, that is available in my area. But so you'd be okay with any plain lactose free yogurt?
Yeah. Green Valley also has a cottage cheese now. So there are more fermented foods available on the market, and I would encourage your listeners to have small amounts of them to begin with, see how they sit. Again, we're talking digestive ability, see how it works. There can often be with a new food or supplement about 3 days of discomfort. If it goes on for longer than 3 days, then you probably want to avoid that food. But when we introduce new bacteria to the system, it needs to find a place or a niche or a home. We want to feed that bacteria. It could be a beneficial bacteria that's causing symptoms. So what you want to do is decrease the amount of that food, but continue to introduce it at a low level. Again, we're talking about 3 days of discomfort. And it shouldn't be so bad that the person is keeled over, kind of discomfort, but more just grumbling or a little bit of bloating. And it's not necessarily a bad sign. Mm-hmm. So it's important people know these things.
Yeah, I think as the specific carbohydrate diet can really have a hold over your mind, just because it has this almost mythology behind it, and a very compelling story, and a lot of people who've had success that everyone's aware about. So I've seen that when people try to introduce foods that are outside of technically what's allowed, they can feel, maybe get initially a little bit of a intolerance to it, but over time they do well with it, but they still feel guilty about eating it, even if they know in their body is tolerating it fine. And then eventually they'll just stop eating that food because it's just psychologically, almost on a subconscious level, it bothers them that they're going outside of what they're supposed to do.
Yeah. Yeah, food definitely has a psychological effect that bypasses the intellect entirely.
Right. Yeah, because ultimately the real thing is how you tolerate it, not based on what a book says or what, that's the most important thing, and I think that gets lost. If you eat something and you do well with it, I think it's this subconscious thought that, maybe this is driving the inflammation and I'm just not feeling it. And I mean, that's true. That could be happening. I mean, you can't completely rely on your symptoms. So I think that's part of why people get afraid.
Yeah, and this is where you need to distinguish between acute symptomology and systemic inflammation.
Right.
It doesn't mean, all that like saturated fat is good for your heart, even if you don't feel it.
Right.
It's not good for you. But yeah, your point's well taken. I mean, there's such a psychology of eating, and pleasure is so important. And I don't want anybody long term to feel so deprived. That's not a way to exist. You need to have pleasure when you're eating and sharing with friends and family, and so it's very important with the IBD-AID that it's a diet that can be shared by the entire family, kids on up, and I deal mostly with adults, but it's fine for nutrients. We're not depriving anybody of the nutrients necessary for life or the flavors important for pleasure.
Mm-hmm. Okay, so quickly, I just want to go through some of these other things that are included in your diet but not included in SCD, and just if you can just make a quick comment on that. So, like tofu is allowed, not allowed on SCD.
Tofu, I recommend only organic.
Okay.
Only organic, and this is because it's as wheat is and corn is highly genetically modified.
Okay. What about flax and chia seeds? Yeah, I think you mentioned that before, that those are pretty well tolerated for most people.
Yeah, well tolerated. Needs to be ground. The chia you can soak. The flax you need to grind it.
Okay. Tamari is also allowed, not on SCD.
Oh, so. Sorry. Yeah, wheat free. Yeah.
Wheat free. And so, what about soy sauce? Soy sauce is derived from wheat.
Yeah, no, I don't recommend it.
No soy sauce. Okay. Stevia. You're okay with stevia?
No.
No?
I don't like any artificial sweeteners, only the stevia extract.
Okay.
So Truvia is not allowed.
Okay.
And again, we get into what the manufacturers have done to that product. Mm-hmm. They've changed it in a way that makes it inflammatory.
Okay. All right. What about maple syrup?
Maple syrup. Oh, I got a story there. So I thought, well, maple syrup, like honey, it's natural. It doesn't have those, the bacteria or antibacterial component that honey does. But I've seen that for some folks, they can tolerate it fine if they don't have it all the time. But particularly for kids, I do not recommend it. I took it out of my list. It seems to still be floating around there. So I essentially don't recommend it, but consider it one of those foods that somebody might be okay with from time to time.
Okay. And that would be the pure maple syrup, not the fake stuff. Okay.
Right. No too much. Right.
Cocoa powder?
Cocoa powder contains polyphenols that could be really helpful. Chocolate. It could be absolutely fine, but needs to be sweetened, to be palatable. And so you want to sweeten that with a really good local honey or organic honey. Okay.
Well, what about if somebody wants to eat some like dark chocolate that's, very natural? I have actually haven't eaten dark chocolate in a while, so I don't even know what's in the ingredients besides the cocoa. But what do you think about just eating dark chocolate?
Dark chocolate. Well, IBD folks are a little bit more sensitive than my other folks with autoimmune diseases or inflammatory diseases. And so you can find dark chocolate that's honey sweetened, like even commercial. You gotta be aware of the other ingredients.
Right.
Most chocolate is sweetened with sucrose. And then you get it, well, what percentage of cacao? And I think 85 is pretty bitter. May be okay if you have a square and you have a good microbiome going. A little bit of sucrose is not going to hurt you if you only have it from time to time. And so that actually has worked well for many of my patients who are chocoholics.
Okay.
But not regular basis
Right.
or a lot at any given time because
Okay.
of the sugar. Yeah, it's not the chocolate, it's the sugar.
What about steel or the whole oatmeal thing? What kind of oatmeal would be okay? Instant oatmeal, steel cut, rolled oats.
Um, Instant doesn't do anything
Okay.
of benefit. The steel cut definitely help. You need to cook them very well if you're sensitive. The oat groats, Groats, is beneficial. Cook them well. The oat groats are really versatile. They work so well as a savory dish where you can like make them into casseroles. You can have them as a side dish. It's a rice alternative. It's just you could throw it into soups instead of noodles. So when you take that step to the actual whole grain, it lends itself well to a culinary medicine. That steel cut is still like a cereal. Rolled is a cereal, and rolled is quickly digested and absorbed and may not have all of the benefits of nourishing the microbiome that the slower digestion encourages of a larger particle size.
And is part of the reason you went with oats as kind of your staple grain here is the that it's virtually gluten free?
It is naturally gluten-free, but it's also a really good source of soluble fiber. And the soluble fiber is fermented by the gut beneficial bacteria, but it's also something that will swell and bind with blood fats and carry them out of the body. So it actually helps to change metabolism of the patient to be one that's more efficient.
Okay.
If we have enough water on board. So I don't want it to swell right there in the stomach, but get down to the gut where it does its magic.
Are you aware of that Japanese study about the semi-vegetarian diet that was a case series published several years ago about patients who were medically induced remission and then they were able to maintain remission on this kind of semi-vegetarian Japanese diet. And one of the foods that they included in their diet was rice. What's your opinion of rice?
I think rice is, especially if it's good quality rice, can be allowed, and sometimes, depending on the person's genetics, even from the beginning. I prefer to leave it out of my phase 1, but it can be reintegrated as the patient achieves remission. And the thing about rice is I think of it's neutral. It's not necessarily going to help the patient other than psychologically, but physiologically, I haven't seen the same impact upon the microbiome as I do, for instance, with oats or barley. So I think of rice as a neutral. It's not necessarily harmful, but when I really want somebody's microbiome to change, I don't use rice.
Right. And that makes sense because most of it is absorbed in the small bowel, especially white rice. Before, at least theoretically, most of it doesn't get to the colon. A lot of it's absorbed. So, all right. And then things like mustard, mayonnaise. I saw some of these in your food list. Are these things that need to be made from scratch, or can people buy them from the store, like some, honey mustard or spicy mustard from the store, and would that be okay? But do people have to actually look at the specific ingredients again?
Yeah, they have to look at the ingredients, and again, a lot of producers are coming up with some really good alternatives. They can be very expensive. Somebody might prefer to make them from home and avoid that type of expense, but I'm really gratified to see that there's a lot of really good products that are coming out almost on like a monthly or bi-monthly basis. I'll come across something else that, I want to try.
Sure.
For instance. Yeah.
Okay. I saw vinegar in one of the lists as something that's allowed. One key distinction and something that's very actually important for people who are following SCD or your diet is salads. Salads are a very common food people eat, and then a lot of times balsamic vinegar is the only thing that's available as far as a dressing. The SCD makes a very clear distinction that balsamic vinegar is not allowed, although red wine vinegar or white wine vinegar are. Does your diet make a distinction between those?
And then I want to throw in umeboshi plum vinegar. I love umeboshi plum vinegar. So the vinegars all are slightly different, but as long as the patient achieves a very good quality vinegar and they use it in smaller amounts, they're probably going to do okay with it.
Okay. So balsamic would be okay as long as it's like a good quality.
That would be okay.
Okay. Hot sauce that is sugar-free. So,
the patients have taught me this one. Not only hot sauce, but also like jalapeno peppers and, hot spicy foods. They can be just fine. And it just depends on the patient. And these are also foods that are in the nightshade family, and I don't know if you guys know about the Tom Brady diet thing and inflammation. There are very few people who are intolerant of that botanical family, the nightshade. Maybe there are some, and hats off, we can go with that because they're not essential to the diet. But yeah, you got to get a good quality sauce, look at the ingredients. But some of these spices, ginger I would throw in there, garlic, some of these spices could be really flavorful and tolerated just fine.
Okay, so you don't have any issues with lectins, right? I think that's one of the reasons people try to take nightshades out.
Yeah, long as they're cooked.
Cooked, okay. And then as far as the beans and lentils, do they have to be prepared in a certain way, like soaked for 24 hours or?
I think that's the best way to do it if somebody's having trouble with tolerance. But some of the canned products, the way that we are canning foods is very different in what we're using in the cans than was during Elaine's time. And so now there is not an interaction between the can and the food over time. Mm-hmm. Some of the good companies will have canned beans, for instance, that can be well digested. If one is cooking, which is preferred for digestion and absorption, then we do want to soak it. Adding the kombu or seaweed to the cooking water is also very beneficial. And then, again, taking the extra step to pressure cook or puree the beans can also improve digestibility.
Okay. What about omega-3 eggs? Do eggs have to be omega-3 because they do?
Yeah.
Okay.
Yeah, they do. Those omega-3 eggs, so when you get omega-3 eggs, they're also a marker for chickens that have been raised better. We are what we eat, so are the chickens. If they feed them good feed, they're more likely to be free range, and it actually affects them tremendously. It changes the fatty acids in the eggs, for one, away from saturated fat to omega-3 fatty acids. It's just fascinating that what the farmers had known for a long time, we're only now starting to integrate with people. Mm-hmm. We are what we eat, for sure.
What is your attitude regarding eating a lot of meat in general? What can happen when you follow SCD is because, or really any of these diets where a lot of the grains are excluded, is you need to substitute it with something, so you end up eating a lot of meat, a lot of cheese. But specifically regarding meat, do you have any recommendations as far as like limiting it to a couple days a week, or can somebody just eat unlimited meat on your diet?
No, I never recommended unlimited meat. It's difficult to digest. It tends to putrefy longer in the colon than other animal products, like fish. Maybe we can consider there. Fish goes through more quickly and actually has a higher impact on protein stores than animal foods. The only reason I would want somebody to eat red meat would be if they're so anemic. And then at that point, we want to kind of put them onto the ground meats and make sure see if we can do grass-fed. I think, again, going at the animals are what they eat too. I am more plant-oriented, but a lot of that is oriented because I'm looking at micronutrients that are essential for healing. And so when you have a meat-heavy diet, you don't have as many vegetables. And so I want a vegetable-heavy diet with meat as a side.
Mm-hmm. Right.
Or meat protein or something.
This is an area of contention amongst people who have different philosophies about this. I've spoken to, there's a whole community, that believes that vegan diets are the best for IBD and for health in general. There's this whole movement of this whole food plant-based diet. A lot of people are, adopting in clinical practice. So what do you think about going to the other extreme of being like completely plant-based, especially with these conditions?
I want to customize that to the patient. So the problem with that is that the patient may actually end up quite deficient and not achieving absorption of nutrients because it gets into removing the heme iron that may be important for patients with IBD who have anemia. We also want to make sure that they've got balance in the diet. So I can have a vegan diet that's really high in foods that aren't nutrient dense. Mm-hmm. Whenever you narrow the diet that much and not have enough variety, I would suggest that the person may want to do an assessment to make sure that they're getting enough of what they need. And it's not that I don't believe in vegan diet, because I think it can be incredibly healthy and beneficial, but we need to make sure of that and that it fits with the individual. And sometimes somebody having chicken from time to time or meat from time to time or eggs from time to time can be just fine.
Mm-hmm. Sure. Okay, and what about drinking fruit juices? Like the SCD specifies they cannot be from concentrate, they have to be fresh squeezed. Is your protocol that strict with regard to fruit juices? Do they have to be diluted, half juice, half water?
So get a good quality juice. It can be commercially derived, but a good quality juice. Organic is always my go-to, and I want people to dilute it. The problem with juices is that we get into a situation where we've got fruit water, and it doesn't have the phytonutrients of the fruit itself that can be nourishing. So I don't want to use it as a substitute for the fruit.
Okay.
And I think Elaine was on the right track there. And, but I'd rather have them puree the fruit, I suppose, or have the fruit than go for the fruit juice.
Mm-hmm. Okay. And I'm going to give you a couple of food scenarios, and I just want to see what you think of this in the context of somebody following your diet. Would this be appropriate? Because according to the SCD, it wouldn't. And so I just want to, get a sense of if this would improve people's ability to eat out or not feel so anxious because of all the restrictions of the SCD, if your diet would be something that would improve quality of life from that perspective. So let's say somebody goes to a Mediterranean restaurant and they order like a chicken shawarma platter, like the chicken that they kind of carve off of that big rotating thing, and it comes with salad, and then let's say there's like a tahini sauce and a hot sauce. And that's it. It's just salad with chicken and a couple sauces. So is somebody on the IBD-AID diet going to speak with the chef and say, hey, what is exactly in this chicken? What did you actually put in here? What's exactly in the sauces? Or is somebody on the IBD-AID just going to eat that without a problem?
If I've got somebody who's in remission, and they've been in remission for months or years, and I do have many patients in remission for years, they may be savvy enough to be able to order that. But I would still suggest talking about the ingredients. And there's some people who will never be able to tolerate iceberg lettuce. It's just one of those foods that it's not because of any nutrients in there or fiber in there. Just a lot of people just can't tolerate it. They're not good chewers. Tahini can be fine, sesame butter. So people can go out to eat, but it's usually my folks who are in remission who can do best. And usually what I recommend is you have some digestive enzymes, maybe some probiotics, it depends on the patient, before consuming foods that are made by others' hands.
Got it. That makes sense. It seems like, the SCD was all about being fanatically adherent. That's the terminology they used. But from your perspective, it seems like it's almost on a sliding scale. Like if you're pretty sick, just starting out, you should be more strict than if you're years out on the diet and feeling well. Maybe you can take, some liberties as far as being so strict with everything, which can be very cumbersome.
Mm-hmm. Yeah.
Okay.
And isolating.
Yes. And and this is something that I've wrote into my review paper on diet, is that you really have to be vigilant, the clinician and the patient, as far as how this diet is affecting somebody's quality of life. Yeah. If it very easily can get into a scenario where it's actually compromising your quality of life, and the patient really has to be cognizant of that. I think there is a transition period where you kind of have to, the diet's obviously not going to be enhancing your quality of life as you're getting used to it. But if you're years down the line feeling like you're not getting the results you need, and it's also completely destroying your joy in life as far as socializing, a lot of socializing revolves around food, then you have to reevaluate it. But at the same time, having active disease is pretty bad too. So for each patient, it's an individual decision as far as going forward with this. What about if you're at the airport and they have a chicken's, they have those refrigerators where there's a salad with some chicken in it.
Yeah.
In my experience, that chicken is not pure chicken. They usually have some sort of texturized vegetable protein or something like that.
Nasty stuff, right?
Okay, so you would not be in favor of people eating that, because
no,
that chicken that you find at ABP in the salads, or that's not real chicken. It has some kind of filler in it that tends to be.
Yeah, no, not good.
Okay.
Yeah.
And is there any fast food place that could be safe according to your protocol? Are your patients going to certain places and finding stuff?
Well, no. Name a fast food place. What do you think? Is there?
Well, according to
burger places, no.
Well, what about? Well, there's two that come to mind, and this is mainly from the STD community. And I don't know if these are technically legal, but I remember certain people saying online, this is where they go. Somebody will go to In-N-Out Burger and get something called, I think it's called Animal Style, or where it's just a lettuce wrapped beef patty with onions and tomatoes, and that supposedly the beef at In-N-Out is just beef. I can't really confirm or deny that, but that's one. Another one is Qdobo, which is kind of the knockoff of Chipotle, but it has supposedly they you can get a salad bowl with guacamole and bell peppers and onions, and I'm not sure if the chicken is safe, but you can at least get a vegetarian type of salad there, and it should be okay. I think the problem with Chipotle is they use soybean oil, which is not allowed according to SCD. So I was just curious if there were people, one place that I think is decent, maybe if you're more advanced, is actually going to Benihana. It's not a fast food place, but they do use safflower oil to cook, but you see what they're doing in front of you. And
it's helpful.
yeah, and you can request to not have soy sauce in the food. And then from that perspective, it'll probably be okay. It is a meat-heavy dinner, though, but that is another possibility to consider.
I have some folks do well with sushi.
Right.
Yeah.
With the rice? Or sashimi?
The rice, the seaweed, the fish, the raw fish. It's prepared in front of you. It's so that can go over well. So I think it's sort of with the adventuresome spirit or the person who's journeying through different geographies. You find what you need to by asking questions, by observing and being aware of what you're taking in.
Mm-hmm. Okay. So I was going to ask you some questions about that 2014 publication. If people want to look this up, it's called An Anti-Inflammatory Diet as Treatment for Inflammatory Bowel Disease, a Case Series Report. And Barbara, I think you're the first author on the paper, right? Mm-hmm. This was in 2014. I know you have some, this is, a few years old, and you've updated the protocol since then, and you have other publications coming out. So I won't ask too many questions about this, but the main one I had was a lot of these patients were on medication or had been on immunomodulators, biologics in the past, or were subsequently stayed on them. It seemed like they weren't having good results with them, or they had lost response. Then they went on this diet, and then they did better, the 11 patients on this case series. So just in general, has it been your observation that a lot of the patients you see in your clinic are on medication and continuing medication along with the diet? And what is the distribution? Is it mostly those kind of people, or are you seeing a lot of people just being on diet by itself?
Really good question. I have hundreds of patients at this point, and I would say that most of them are frightened enough to have to go on medication. And so the diet is a complement to the medication and can improve the response of the patient. So medication alone may not be enough, and often is actually ineffective entirely, depending on the patient's genetics and that kind of thing. And so the diet, I think, is an essential component of the patient care. The problem is that gastroenterologists aren't really trained in diet and don't really know how to counsel their patients in diet. You may be an exception to this, but most gastroenterologists are really skeptical that diet has anything to do with IBD. It's only recently, with the research and the pioneering patients going through the SCD and the IBD-AID and other kinds of things, that are showing their gastroenterologists that diet can indeed make a huge difference. And I've got several case studies, as well as now we've got some research studies that we're about to publish. Giving people their lives back. I have people, there's a fellow in North Carolina, and he was told that his intestines looked like a minefield in Afghanistan, and they recommended a total colectomy. He decided to initiate Humira at some point, also did some methotrexate, and the diet. And over time was able to discontinue the Humira after about a year, discontinued the methotrexate after about 6 months, and is now completely diet controlled and has his colon and is working, and has a family and participates in life and hears music and goes out to eat. And, that's what it's about.
Mm-hmm. Yeah, I mean, these stories are very powerful and give people hope that something like that is possible. And I personally think that using that combination of medicine and diet is really the most potent thing, because have you had people who have just been adamantly opposed to medication and just want to do diet. Because I've seen patients like that too, and some do well with diet if they, in my experience, people who have relatively mild disease, but with severe disease, just doing diet by itself, it's taking a big risk. Because I think at that point you really need to do as much as you can to control the inflammation, and the more you kind of sit on it, because diet is more of a long game in my perspective. As far as I think it's better at maintaining remission. Inducing remission, it can work, but it's not. The results take longer, and sometimes people are in a situation where they got to get things under control very quickly.
Yeah. And so I would never stand in the way of that pathway. But if somebody decides not to do the medication, I have seen people respond very quickly to diet. But at that point, if we've got somebody who's like on the edge of the cliff and they're about to go over, and you've got to do everything you can to stop that event from happening, they need to meet with somebody who's able to really coach them into very quick compliance to the dietary components, to make sure that they're getting everything they need kicking in as soon as possible.
Sure. What has been your observation regarding Crohn's versus ulcerative colitis responding to diet? In my experience, I don't have randomized control trial data to support this statement, but based on the pathophysiology of these conditions and what I've seen, I feel like Crohn's responds better to dietary manipulations than ulcerative colitis. Is that something you've observed, or is that not your experience?
Isn't that interesting? So I would say, and this is subjective, that UC responds quicker than Crohn's.
Okay.
But both respond equally well. Crohn's, ileal Crohn's, can be tricky.
Mm-hmm. Because, I think Elaine Gottschall had mentioned in one interview I saw of her that she felt like small bowel Crohn's actually responded the best. I think Crohn's colitis probably works the best. And I'm talking more in the context of SCD. Maybe things would be different according to modifications, more modern modifications that are being used now. But so you feel like small bowel or ileal Crohn's is actually the least responsive?
Well, possibly. I'm looking forward to our current studies ongoing in really distinguishing different types of Crohn's and how they present. I also want to throw in microscopic colitis. It responds really well.
Really? Okay.
Yeah. And that traditionally, and in fact, we can get a response with microscopic colitis that's astonishing.
Wow. Interesting. Okay.
Those are case studies.
Sure.
We need more patients. And nationwide, I want to give a shout out. We are recruiting for our current study in pregnant women, both healthy. We have healthy controls, and they get paid, and they submit stool samples, and we look at the microbiomes of the women and the babies. But also women with Crohn's disease who are pregnant, and we change the diet or not. So there's a third arm where the Crohn's patient choose not to change their diet. And we follow the women out and their babies and look at the microbiome of the women and the babies.
Okay.
So based on a previous study done at Mount Sinai where they just did observation looking at Crohn's versus healthy controls and saw that babies born to women with Crohn's disease had a less diverse microbiome than the babies born to the healthy controls. Doesn't mean the babies weren't healthy, but they were vulnerable to an epigenetic trigger.
Mm-hmm.
So,
and I'm sure. Sorry, go ahead. Another issue that comes up is, some patients are on medications that make them reluctant to breastfeed. And I know breastfeeding influences the microbiome as well. Even though there's really no absolute contraindication to breastfeeding, there's usually ways around it depending on what medication somebody's on. But also sometimes people choose not to breastfeed because, especially if they're flaring with IBD, it can be a very stressful time. I do have a patient. I've seen a few patients who were even on like cyclosporin and recently delivered a baby, and had to come to frequent clinic visits, and as far as breastfeeding, with all of that going on, can be very difficult to do.
Yeah. So some of the studies show that there's actually a better correlation, which is why we're doing this in the third trimester, between the mom's gut and the baby gut than there is between breastfeeding and the baby gut. So, but there is a correlation, and I'm working with a mom right now who's breastfeeding her daughter, and she had to go on antibiotics for mastitis, and her daughter is experiencing the diarrhea just as she is, and so we're working with particular organisms to try and modify that, but it'll be a bit of a battle to get back to her baseline. You can breastfeed through it, but it takes some determination.
Mm-hmm. So just anecdotally, just want to confirm this, you have seen patients who were not doing well, went on the diet, and then not just symptomatically got better, but had mucosal healing, right? Like where they do a scope and everything looked normalized.
Right.
Okay. Have you had patients who have tried this diet and you were confident they were doing it properly and did not respond?
Yes.
Okay.
And I don't know yet why some people respond and others don't, whether it's compliance or something in the environment or lifestyle, or whether it's genetics. I don't know that yet, Samir.
Okay. And what is the time frame for people who do respond to get the full response? Is it similar to SCD, which according to my case series, it was about on average 9 months to a year or so?
Oh, gosh. Response. So tell me, what's your definition of response?
So this would be clinical, like pretty much feeling completely normal clinically.
So remission.
Right.
Okay. I think that's pretty much my experience as well. It could be, if it's symptomatic, because a lot of times we don't do colonoscopies or sigmoidoscopies, at certain points in time. But so we looked at symptomatic remission. You can achieve symptomatic remission pretty quickly, depending, and the younger you are, the quicker you can achieve it. And then, of course, I think genetic sensitivity plays into it. So that's certainly within 2 to 6 weeks, you've got a response. It may not be a remission, complete remission of symptoms. I don't think it takes 9 months. Okay. I probably is less than that, depending on, compliance and other issues.
Okay. And have you observed people who see you because I think a lot of people find the SCD first, but have you found that people who follow the IBD-AID diet and maybe not getting the results they want, then transitioning to SCD and actually doing better on SCD? Because it seems like you've seen a lot of patients who are on SCD not getting optimal results and then transitioning to your diet and with your additions and feeling better. But have you seen the reverse scenario happen too?
So I have seen folks who say, we're not where we need to be. What do we need to do? I don't think it's necessarily adopting another dietary pattern that appears to be the solution, but it could be some of the principles of the SCD from food to food. Say like, okay, these foods just don't work for me. Even like oats just never work for me. And it was like, okay, we can get there. Oats are not the only source of, prebiotics and nutrients and binding of the stools or whatever we're trying to accomplish. We can just leave that out. Mm-hmm. So it may not be the legal, illegal, complete adoption, but it can be certain foods that just don't work well for somebody for whatever reason.
Okay. what do you think about the Mediterranean diet for IBD? For some reason, a lot of gastroenterologists are, whenever it seems to be like the go-to answer for a lot of them as far as when patients ask, what kind of diet should I be eating? And a lot of times they just say, follow a healthy diet, and then that ends up being the Mediterranean diet. Any issues with that?
It's probably better than the standard American diet. Anything that gets somebody into the kitchen preparing healthy, fresh foods. But I think if somebody's in a flare, they're still going to have to modify those foods in order to be successful.
Okay. And what about the autoimmune paleo diet?
I think this could be problematic because of the emphasis upon animal protein and saturated fats. And so, and to that, we look to the cardiovascular literature where I see that it's really increasing certain inflammatory markers. And so I would be leery of keto in particular. But so sometimes I have a patient now who's cardio, and he's on a I put him on a modified paleo because it fit with his lifestyle, but the emphasis is on increasing non-starchy vegetables for him and, maybe having the beans from time to time and not so much emphasis on the animal protein.
Okay. All right. And do you use exclusive enteral nutrition in adults with Crohn's? And do you have any tips for implementing that?
I do. From time to time. And so my tips for that is to not rely upon commercial formulas unless there's some mitigating circumstances in the life that we have to, but we make them from home.
Oh.
From real foods. Yeah. And it's just blenderized nutrition.
Okay. So that still should, for example, how would somebody do that? What would they blend?
Well, you might say, and then we get a variety, so it's not the same thing all the time, but say basic ingredients. We need a protein source. What do we use for our protein? It could be that we've got pasteurized egg whites. We might throw in some yogurt. We might put in some nut butters, so these can all be sources of protein as well as beneficial fatty acids. Then we might throw in some vegetables. I often go to leafy spinach, which should be cooked for best absorption, some other vegetables that can go into there, and some fruits, and then consume the product. It's a smoothie.
Mm-hmm. And my understanding is there's no data as far as if that would as far as making like a polymeric formula or enteral nutrition from whole food sources, if that actually would induce remission to the same, or if it's been compared to standard polymeric formulas. But in your experience, has that worked? Because usually the protocol is like doing that for 4 to 6 weeks with just having that only. And that's supposed to be almost as good as steroids in adults for Crohn's disease.
Yeah. So what I do, Samir, is I do encourage it, like smoothies and soups, for instance, blenderized soups. And the advantage of this is that we get a difference in the microbiome. So after the end of that 6 weeks, we've got a diverse microbiome as opposed to the commercial formulas or polymeric formulas, which decrease the microbiome.
Mm-hmm. Right.
We may have symptomatic remission, and because of the texture, we're no longer sandpapering the friable tissues, but we don't have the long-term foundation of healing.
Mm-hmm. Okay. Yeah, I've had patients who have had active inflammation and have tried to just be on a soup diet or, just eating soups, and at least from my observations is they didn't do too well with that. But that's only like a handful of people I know who've tried that. But I definitely know a lot of people who've done the enteral nutrition, even though like stuff like Ensure or Boost, they have a lot of actually bad stuff in there, like maltodextrin, like carrageenan, like carboxymethylcellulose. I think it actually has all of that stuff but they still do well with it though. And yeah, it's because it's almost acting like an antibiotic for Crohn's. Yeah. It's like decreasing the biodiversity, but in my mind, it's more of like a reset. And then it's something that I transition people onto dietary therapy and with medical therapy from there.
So sometimes we have to do something temporary in order to reach the goal, with the goal being the most important component. And that you say to yourself, okay, we're going to get them off this bad stuff in a few weeks without causing irreparable harm. Mm-hmm. So that's sort of an individual case-by-case decision.
Okay. All right. So we're already an hour and a half in. I was wondering if you just had maybe 5-10 minutes more, just to actually, a lot of listeners submitted questions for you. Some of these we've already gone over, but is that okay? Do you have a few more minutes?
Yeah, sure.
Okay. So these came in through email and Twitter. So the first one is, so I believe, this is a direct quote from the person. I believe there is confusion in how to best apply IBD-AID in the presence of more complex IBD. Some are pushing plant-based exclusively, but I'm very concerned for me and other patients who find that too many plant foods can cause issues.
Okay, I validate this person's concern, and that's why I don't want to make it a black and white where it's only plant-based or only, has to have animal foods in it. This is an individual decision. I would recommend that if one is going to have animal foods, that they're of higher quality, that they choose to eat animals that have been fed well and raised well, so that they're not having, and also avoiding those particular components of chicken that really aren't chicken. So it's, and sort of modifying the vegetables so that they are acceptable to the gut.
Mm-hmm. Okay. Do you think there is a place for personalizing the diet, like making it a lower FODMAP version of it in FODMAP sensitive patients, or lower starch? And for this particular person who submitted this question, it seems like starches were a trigger for some sort of HLA-B27 associated disease like ankylosing spondylitis or sacroiliitis.
Well, in which case we respect that and customize the diet to the patient concerns. I think that is actually a priority of mine, and why it's so difficult to come out with like one diet size fits all. We do have to customize the diet.
Right. Yeah. Another person asked this relevant question: could you standardize the diet so that it could be reliably replicated and controlled? He said, right now it looks like more of a list of possible safe foods, but that goes to your point that a lot of this is personalization based on the many issues that can come up with certain food components.
Yeah. So this is where nutrition itself can be difficult. Like the USDA has dietary guidelines. And so I think of this as IBD guidelines, dietary guidelines. And where we do have sort of, okay, we need to have certain nutrients, and we want to make sure to include them on a day-to-day basis, but which nutrients or foods you choose to satisfy those requirements should be an individual choice depending upon taste and how well that sits with their particular situation.
Mm-hmm. Okay. And the last question is, the villain of SCD is polysaccharides. IBD-AID, while based on SCD, notably includes quite a few: oats, sweet potato, chia, flax. How are these polysaccharides different from other polysaccharides, and how do we know they're not feeding bad bacteria just as much as good bacteria? And a related question is, is the science actually clear about that as far as which carbs feed bad bacteria versus good bacteria?
So that's a really valuable question, and one that we are always testing in research. And so what we do is there's a study that we will be publishing soon that we had a variety of patients, both Crohn's and ulcerative colitis, all adults. And they served as their own controls. And so we tested their microbiome with their current diet, as varied as that might be, and then initiated the diet and tested the microbiome. And then we also did a fair amount of dietary assessment, looking at these components of the diet. And so what we know is these particular foods, and you named them the polysaccharides, are shown to be beneficial for particular colonies of biota necessary for production of the short-chain fatty acids and perhaps other metabolic reasons.
Okay. What is your opinion about Genova testing? There's a Nutra-Eval test that people are getting to figure out their nutritional deficiencies, toxicities, mitochondrial function, all that kind of stuff. Do you have patients coming in with those reports? And
I do, and I take them with a grain of salt. And that's not to say that there isn't some validity to it. I think that there is, and I look at the different parts of the test, but I think we've gone too far, we're overreaching our ability to really definitively say this food does that or that food does this. It's a combination of foods that will accomplish the end goal. And I worry a little bit about the expense of these tests, and that they're not really giving us what we need in terms of answers. And I have specific examples of that with some of my patients. It can be helpful, and if you got the money to spend, then why not get some information? But the research isn't there yet. It isn't there yet where we can apply these results clinically.
Okay. Yeah, I mean, there's people getting this testing done, and then as a result, spending a lot of money on supplements, taking different amino acid supplements and vitamins, minerals. So I was just curious what you thought of that. So it seems like it's not ready for prime time.
No.
Yeah.
I think it's taking advantage of a vulnerable population.
Sure. Okay, well, that's we ran through. Sorry for any listeners who sent other questions. I think I covered most of them. But again, thank you so much for your time. How can people find information about you, your center, and also, like, what's your website?
It's www.umassmed.edu/nutrition. And under that site, go under IBD, and there's a whole menu plans and recipes and different kinds of information, as well as a contact for our current recruitment effort nationwide for pregnant women.
Okay. And is it possible for people to, as far as seeing you in the clinic and stuff, is that only done in person, or is there a way for people to do, like, I don't know, telemedicine or phone consults or anything like that, or is it strictly at your center?
I do a limited amount of telemedicine. I'm trying to distribute that a little bit more with my trained IBD dietitians that we have in our Center for Applied Nutrition. And I certainly will see anybody and everybody in the clinic who wants to come. Okay. And we'll have, like, cooking classes that we have from time to time, which is really fun because you sit down and you eat good food and you're with good people.
Great. Okay. Any last words for people as far as words of wisdom from your many patients you've seen? I know we've gone over we've covered a lot of ground over this conversation, but any final words for us?
I'm like the eternal optimist, and I never give up on anybody. And I would encourage people to continue to have hope, that if they don't have the answers that they're looking for, to continue to search, because and it could be by changing practitioners or seeking out additional information. There is an answer for each and every person who has this disease. We're going places really fast, and I really appreciate the work that you, Samir, are doing, and other people like you. things are changing, and I like what I see.
Yeah, great. I'm starting to shift my focus. I was very heavily into research, microbiome research, and now I see my role mainly as implementing these things clinically and also getting the message out. I see myself as somebody who I want to talk to people who are doing new things, new and exciting things in IBD, and getting the message out. And now, we have a lot of people tuning in every week. It's like 500 to 1,000 downloads a week on this podcast all over the world.
Wow.
And I'm getting messages. So for anybody listening, please, follow me on Twitter. You can ask your own questions. I won't ask all of them, but sometimes if I cover something during the conversation, I don't ask it. But I feel like with each podcast I'm doing, not only myself, but everybody else is learning just a little bit more, and we're inching towards coming to the truth of really how to tackle this disease and what is the optimal way to do so. And it's different for each person, but every podcast, it's almost like my thought process about these diseases changes a little bit, and I'm getting better and better myself with regard to being able to help these kind of patients.
And so do we send patients to you, Samir? Can I do that?
Yeah. I mean, my clinic, the information for my clinic is on my podcast website, but pretty much I work through a hospital called Advocate Lutheran General Hospital. I was at Rush, but I've now transitioned to Lutheran General, which is in Niles, Illinois. My contact information is on the YouTube information as well as on my website. You can call, make an appointment. I have had people come from different areas of the U.S. to see me, so I'm always open to see. I actually like seeing patients who have IBD and are interested in these kind of things, because I know that it's hard to find somebody who is understanding and is even familiar with a lot of these kind of complementary alternative treatments and dietary therapy. So definitely if you want to see me as well. Otherwise, feel free to enjoy these podcasts, which I'll continue to do. And I always learn something, and I hope everybody else is learning too.
Thank you so much, Samir.
Okay. Thanks for your time. Thank you. If you made it to the end of this podcast, I thought I'd throw in an Easter egg for you. When I post these episodes, I get analytics, and I see which cities in the U.S. are downloading this the most, and almost always Wichita, Kansas is at the top of the list. So if you're listening from Wichita, Kansas, send me an email and potentially just give me an explanation. I'm just curious why this is so big in Wichita, Kansas. But otherwise, again, thank you for listening, and hopefully I'll have another one of these out pretty soon. Thank you.